or it could be the degenerative diseases. So you can definitely classify all your diseases under those umbrella. So let's start the lecture. I think we've done, and this is CME. If you want the link, I'll put the link in the text after we finish, so you can everybody can get your CME. But when I was promoting the event, I was putting the link of the CME for you to gain your CME credit for attending this meeting. It's 2 hours from American Medical Association Category 1, and it helps you to renew your license. But if you need it, I will send you a text, and I will send you the CME link if that's needed. So today we're going to talk about what's the practical approach. What is things that we can do to really restore the metabolic immune regenerative and a more basic things without costing too much of the patients. And more standard things that everybody needs it above 50, especially we know above 50, we end up dropping the 6 hormone. And that's the start of the whole problem after 50. The aging starts after dropping the 6 hormone. So the culprit here of aging and degenerating and having cancer after 50, why all these diseases happen more after 50 than before 50, it's just because the first thing is because of the drop of the 6 hormone. That's really the start of the problem. And if we recognize that as doctors, that is the problem, because once you drop from the 6 hormone drops, then there's a gap there. And what is the gap needs to be filled? It's going to be filled with cortisol. Adrenal gland will kick in and replace the 6 hormone, because you need something to take care of the basic inflammation. 6 hormone used to do that. So you don't need that much of cortisol. But when it drops, then the cortisol needs to take over and take care of the basic inflammation. At the expense of what? At the expense of aging and atrophy and degeneration. So yeah, the cortisone will take over, but cortisone, which is coming from cholesterol, and 6 hormone, which is coming from cholesterol, by the way, what's the difference between them? 6 hormone is regenerative drug, cortisone is degenerative. So the reason why we end up with white hair, we end up with wrinkling face, it's just because of the cortisone dominancy that happened after 50 because of the drop in the 6 hormone and the kicking in and increase in the cortisol, right? That what happened when people are being stressed out emotionally or whether from cancer or from disease, they age very fast. And the reason is just because of the cortisol. So cortisone is the culprit, is the aging drug. It gives you the anti-inflammatory, yes, that's good, but also it speeds the process of aging. And if you do have excessive cortisone, or you're giving to the patient too much of cortisone, and sometimes you need it for a patient to manage them with autoimmune diseases. What it does, cortisone, it suppresses the immune system, but specifically it suppresses more of CD8 and Th1. And if you suppress more of CD8 and Th1, you put the patient at risk of cancer and immune escape and cancer. So that's the reason why when we've been stressed out and cortisone is high, that's the reason emotional stress leads to cancer. Because when you suppress the immune system, it suppresses mainly the cytotoxic T cells, and then you end up with immune escape, and that's where the cancer happened. So if somebody said, yeah, cancer, people, they classify it in different aspects. Some of them, they say it's metabolic. That's why you can manage with the keto diet. Some of them, they classify it as redox. Some of them, they classify it as immune. And other is classifying as regenerative. I say it's a combination of 4. But really what triggered or what caused the cancer to flourish or escape is something that caused immune suppression. Stressful event that leads to too much of cortisone, suppress the whole thing, and lead the cytotoxic T cells to go down, and that's where the cancer have a chance to flourish. Because normally we do have 2 cancer, maybe 4 or 5 cancer cells every day, and we take care of it. Everybody has cancer, developing cancer cells, but we have immune system to navigate that and eliminate them before they flourish. But if you compromise the immune system with stress and with cortisone that's coming up from the stress as a response to stress, emotional stress, then you may end up triggering having cancer. That's why good life, happy life, being supportive financially and socially, it's very critical. Your work and all those things, the more we optimize the environment of the patient and help them, the less number of cancer we can have. In addition to that, you can argue that environmental is also an issue too. And we know that our environment is contaminated with all this microplastics and all those chemicals that we live inside the bubble of plastic, in your home. It's a bubble of plastic. Everywhere is plastic. I can turn around here and I can see plastic is everywhere. So we live inside the bubble of petrochemicals, and all this plastic is made from petrochemicals, and they're carcinogenic. Unless you change your house, and everything needs to be completely Dr. Patel certified, because her house is completely almost cancer-free. She controlled the microenvironment that she lives. And if you go to her house, everything is marble, everything is glass. And she does not eat anything that's contaminated, because she has a board in environmental medicine, so she's doing and what she is or she's practicing what she preach. So that's a good example, and she's here, I think, Dr. Patel. So I like to be like her, and I like to practice what I teach. But I'm an ITP, so my personality is kind of not the personality that I like to be. So let's get into the lecture here. I find something, with buying the copilots and buying 360, Microsoft 360. They have a lot of cool stuff here, but I don't know if you can see the lecture. So I'm trying to transform it into something cool. Let me see here. Can you see the lecture? Okay, good. Can you see what I'm seeing? Comprehensive strategy of managing aging and chronic diseases. Can you see it? Yes. Can you put thumbs up? Can you see the lecture? Can you see the screen? Everybody sees it?
Yeah, we got it.
Okay, good. So basically, we are the generation of the AI, and I believe everybody needs to use it, because using AI is using how much billion? 7 billion, 8 billion ideas and brains, and everything in your website, all the data, it's in the tip of your finger through the AI. But you need to know how to direct it. And they do have their logarithms, sometimes they're being censored. But if you speak with the AI and the AI become friend with you, and you know how to persuade him, you can bypass those censors that they do, and money can censor things. So when you generate a anything COVID picture, the AI will say no, they don't want. But if you say, okay, generate image of SARS-2, then they will generate it, because the people who are doing the censoring thing, they're not that smart. They don't know the difference between COVID and SARS-2. Or maybe they forgot to put SARS-2. So that's how when I put my book of spikopathy, which is written, it's waiting for Dr. Joseph, who's next to me, to approve it as a co-author, and then Dr. Klatz. But Dr. Joseph is being busy with all the patients, and so maybe tomorrow we will finalize it, and it's going to be published. There are two books. One is for photodynamic biomodulation, photoablation, all together in one book, showing all the protocols, so you can have a laser clinic that does everything from photobiomodulation to photodynamic therapy to photoablations, because they use the same laser, just the difference is the wavelengths and the power, and using fiber optics. So that's kind of the new medicine. So you can ablate cancer, you can ablate you can decompress the disc, you can zip the varicose vein, you can do the hemorrhoid, you can do lipolysis, you can do photodynamic therapy with your cancer, photodynamic therapy with infection. So you really can manage everything. Then you do photobiomodulation, you can restore the redox with that too. So I think it will definitely help to cover a lot of chronic diseases, and you have the tools really to manage chronic diseases. Something that's already FDA approved, and it's practically, and it's not something, imagination or fantasy, and the patients can feel it, and there's good outcomes and publication to support photobiomodulation, photodynamic, and photoablation. In the United States, we have a lot of photobiomodulations, but I don't see much of photodynamic therapy here in the United States. In Germany, they have where you inject the photosensitizers and activate with light, or photoablation, which too much is photothermal, when it's heating the tissue and reshaping the tissue, whether the disc decompress it and evaporate the fluid and shrink it, or lipolysis too. You can shrink the fat if they are resistant to be shrinked. You can do lipolysis, and it's good for cosmetic. And you can do varicose, hemorrhoids, you can remove the tattoo. There's many applications, remove hair. So there's a book for that, and it covers those three aspects of laser. So you can have a laser clinic, does everything you want with the guides, that's the guidelines in the book. I'm using the AI, yes, to put all my presentation to be in a form of an abstract that is equivalent to what you see in an IH. And all my presentation from now on is going to be in a published form, and it's going to be published at World Health Network, which is Dr. Klatz it's a nonprofit organization, and we're trying to put something journalist or journals, so it will be like NIH website, right? World Health, and we can publish articles there and their website, and also possibly they would have issues of magazine and things like that, where it can be mailed to you about all these innovations and updates. So Dr. Klatz and we're working on that. I don't know if he's here, Dr. Klatz, but I don't know if you can invite him, Dr. Joseph, to attend the meeting. So aging and chronic disease are complex processes influenced by oxidative stress, immune dysregulation, metabolic imbalance, and impaired regenerative capacity. So where does the cancer fall in? Really, what is cancer? Cancer is abnormal regeneration, right? So abnormal regeneration can lead to cancer and tumors and overgrowth, or can lead to degeneration. Any disease, you can definitely classify them under those four headlines or panels. And sometimes the disease is like a cross between two, which is fine, but you can definitely define exactly where they are. Like multiple sclerosis, it's immune disease, so it's under immune. But does that mean the only way we manage it is restoring the immune balance? No, really need to work on all the other three, right? It's not enough to say, okay, well, we have Th1 and Th17 is hyperactive. Let's go ahead and polarize it back to Treg and Th2. This is immune modulation. This is immune disease, and that's what we're going to do. No, it doesn't go like this. Why? Because if you have leaky gut, those free radical generators will irritate the gliosis, will lead to gliosis, inflammation, and lead to Th17 hyperpolarization again. You need to manage the leaky gut. And leaky gut is considered as redox because you are leaking free radical generators. Those lipopolysaccharides, they are free radical generators. So leaky gut is under redox diseases, oxidative stress disease, right? If patients has mycotoxins and they are fungus infection, what's that? I consider all this chronic infection, we can put them under redox because they release free radical generators. Those chemicals, those toxins are free radical generators, and they irritate the multiple sclerosis. So you need to manage redox, whether it's in the form of chronic infection, whether it's on heavy metals, they are free radical generators, right? And how we do that, of course, the good thing, we have tools now. We have cyclodextrin, will help to bind and chelate the mycotoxins. Cyclodextrin also has some antiviral effect. It also can get rid from the spikopathy, from the spike, can make complex with it and get rid from it. And so it does have anti-inflammatory, by the way, cyclodextrin. And plus, you want to do photodynamic therapy. You want to manage the leaky gut by prebiotic and postbiotics. So, and then is that enough? No, you still need to work on it, because if you have vitamin D deficiency, that's metabolic. But vitamin D inhibits the TH17, by the way. And if you have that, then you have, TH17 is overactive. So we need the vitamin D. Now it is a metabolic, yes, because you're restoring the metabolism, but it's also immune modulator. See, in your treatment, sometimes you're doing 2 in 1. What else? Vitamin D also expressed antioxidants, so it is redox, right? So the effect of it can be metabolic, can be some of it is immune effect. It's inhibiting TH17. You are restoring the metabolism by increasing the level of vitamin D. That's metabolism. You're restoring the chemistry of the body back to normal. And because it's expressed antioxidant and it inhibits the pro-oxidant, so it is considered as a redox modulator. Okay, what else? Well, if you have 6 hormone is low, that's metabolic. But when you do intranasal progesterone, yes, this is the metabolic therapy because it's distorting the metabolism of the body, right? Because you have deficiency of progesterone. And you're increasing your 6 hormone, testosterone, and if you're a male, or estradiol, you're a female. So, but here's the thing, you say it's a metabolic therapy, but the 6 hormone and progesterone, they also anti-inflammatory, and they inhibit the TH17. So it's part of management of multiple sclerosis. It's immune modulator. So it's a metabolic and immune modulator. What else? It also redox, because 6 hormones stimulate the expression of antioxidant enzymes. And so 6 hormone is metabolic. Yes, you start with that because you're storing the metabolism chemistry of the body metabolically. But the effect is also immune because you're inhibiting TH17 and the excessive of TH1 of the multiple sclerosis, and also you're increasing the expression of antioxidants. So that is how you, in your brain, in your mind, how you start managing it and seeing the chronic disease from all different angles, right? Different from the mainstream medicine will say, just give them steroid and give them immune modulators, give them those antibodies that blocks the TH17, interfere with the activities of it, those antibodies. Yeah, but those antibodies, when you give them and you block the TH17, it blocks it everywhere. And then you end up with immune suppression and put yourself in infection. It has to be targeted therapy, and it has to be not suppressing it too much where you end up having infection. And then the bio-friendly product, whether supplement or peptides, they do that. They don't do too much of suppression where you end up you compromise the immune system. Well, with the big pharma products, they do too much of suppression to the point they interfere with the physiological process, and suppressing it to the point you end up with increasing the risk of infection. That's why when they have the propaganda, oh, you use this immune modulators, antibodies, but you have to have a risk of having infection and cancer and all that stuff. So we don't start there. You start with things that does not suppress, and it's more bioidentical, like 6 hormones. That's the first thing you do. If the 6 hormone works like cortisone, but it does not cause atrophy, it does not suppress the immune system to the point where it compromises the immune system, then I will start with that. Just normalize 6 hormone, you will feed the patients with multiple sclerosis, they feel good. Evidence of that, pregnant women, when they are during pregnancy, because they're flooded with progesterone and 6 hormone, they're very high, 10 times the normal. You see the progesterone level goes up to 10 times. Then during pregnancy, they don't feel anymore their joints pain. They feel great. Now, I'll give you another thing about being pregnant. This is something that recently me and my partners, Dr. Platz and Joseph, we talked about. Pregnant women, do you know how much placenta exosomes in their blood? Do you know that the blood of the pregnant women is very, very precious? It's more precious than even young adults. I know that there's some clinics where they provide plasma from youngsters for giving it to the older. Well, here's the good news. Pregnant women, their blood is precious, and its value more than even the youngster's plasma. And why is that? More even than the baby's plasma. And why is that? It's just because when they're pregnant, placenta exosomes from the fetus escapes and goes to the blood of the mother. How much? Is that significant? Yes. 100,000 exosomes per ml of blood. That's mean in any time during pregnancy, they have around half trillion, because how much liter in the blood? It's 5, 6 liters, okay? 5, 6, 7, almost half liter of exosomes, placenta exosome from their fetus. So the whole thing about the women's during pregnancy, they have less of autoimmune and cancer incidents and all that stuff. Part of it is because of the placenta exosomes, placenta-derived exosomes that's coming from the fetus. How much? 100,000 per mil of their blood is placenta exosomes. So anybody there, they will say, oh, placenta exosomes can be carcinogenic. Really? Have you seen any pregnant women? All of them, they have placenta exosomes from their fetus. It's not their own, it's from the baby. And the baby things, it's not them. It's not, right? Your son, you cannot take organ transplant from your son if it's not being matched, right? So these are placenta exosomes derived from their fetus. It's not from their own, escaping. And so they are immune privilege, and the mother is accepting it with no problems. They don't reject it, right? And in fact, those placenta exosomes are very rich with RNAs and proteins that has anti-inflammatory effect, that has immune modulator effect. They have growth factors that helps to the pregnant women to be resilient during the pregnancy, and definitely able to grow a baby inside them. That require a lot of energy and require a lot of healing and require a lot of stress, and possibly that's being provided by the placenta exosomes inside the mother pregnant woman. Now, can the pregnant women donate their bloods, and where the old people can benefit from it? It cannot be done in a commercial way, but it's prohibited by FDA for women to donate their blood, pregnant women to donate their blood for the safety of the baby. But I'm just saying that the pregnant women blood is precious, and that explains why the pregnant women are resilient. That's why they look more rejuvenated. They look more, their skin get more rejuvenation. You can see the glow. They feel happy, right? The pregnant women, although they have pregnancy and it's a lot of stress there, right? But the sex hormone and the oxytocin and the placenta-derived exosomes, all of this helps to restore the redox and immune and metabolic, and make them, kind of super creature that is able to take care for that baby and grow that baby inside them with less stress or less complication. And so that's the secrets of the resilience, and why they don't suffer from rheumatoid symptoms during the period of pregnancy, is because of the sex hormones, and it's because of the placenta-derived exosomes. Does that make sense? That's something new maybe for some people here. So aging and chronic disease represents a significant challenge to global health. Yes, and you cannot do anti-aging. And we know the father of anti-aging is Dr. Klass. Even if you ask the AI, they will mention Dr. Klass, Ronald Klass, which is my partner, and we're working together and putting up medical centers here, me and Dr. Joseph. But you cannot do anti-aging, and the patient has chronic disease, right? You cannot say, I'm gonna optimize your health, and I'm gonna slow the process of the aging, and you don't address the hypertension and diabetes and rheumatoids and autoimmune and whatever underlying chronic disease. That needs to be addressed first. After you manage the chronic disease, then you start doing the anti-aging process, which is health optimization and optimizing everything to perfection. That's where the anti-aging. It's more perfection. It's not just normalizing it to standard health, but perfected health status, right? That's where you slow the process of the aging. And so most of the time, that's why me and Dr. Klatz, we can see that we are working side by side, because I'm taking care for the chronic disease protocols, and he does the aging, and there's a lot of overlap, like 6-hormone, right? I can use it for managing multiple sclerosis, intranasal progesterone that we talked about. That's a good hormone that it can be as effective as cortisol in modulating the immune system. And so the 6-hormone, it is good for treatment of chronic diseases, good for multiple sclerosis, good for rheumatoid arthritis, as we talked about. Pregnant women, they don't feel pain during pregnancy or rheumatoid because of the 6-hormone. It's anti-inflammatory, it inhibits the Th17 and Th1. And then we can do all the anti-aging thing, methylene blue, and things that helps to enhance the mitochondria, empower it, doing all this exercise, diet, supplement, yeah, and trying to activate the epigenetics as much as you can to produce more of antioxidants and balance that, because when we grow in age, you will end up with pro-oxidants activities is more than antioxidants. With age, the pro-oxidant enzymes, they get active, and antioxidant, they get inactive epigenetically. So what you need, and then that produce more free radical than the antioxidant capacity to neutralize it. So you have too much of free radical ratio over the antioxidants when we grow up in age, right? And nitric oxide also drops. 6-hormone drops. Your stem cells levels start dropping, and exosomes from the stem cells drop. All of this, we can go ahead and work on giving it from outside. It's going to be costly, but we will try to do it in a way stepwise, so it will meet with the patient's status. It's all about the status of the patient, because it costs too much to do all those things at once. But with a smart way, you can definitely, exercising, with diet, with good sleep, all the things, you do the basic things. You don't jump and give exosomes for a person he doesn't sleep at night, so he does not detox. Is hypertension, diabetic, obese, a lot of fat, and say, oh, come candy shop, let's go ahead and give you exosomes. Oh, go to the bed, to the light. Those candy shop clinics that we know, that needs to be stopped. We really need to come up with a strategy based on the data of the patients, based on the lab, based on his history, physical exam, based on the diagnosis, and come up with the plan to restore it. And it has to be efficient. You just don't jump to the exosomes and stem cells. You're throwing fertilizers in a desert, or fertilizers where a lot of weeds, right? And what would happen? The weeds will get benefit from those fertilizers. In fact, if you give those exosomes and peptides randomly, where the patients have inflammasomes and precancers, you're actually causing more problems. You're feeding the inflammasome containing cells and those aging cells, and you're making things worse for the patients. You need to get rid from those before you give the fertilizers. Otherwise, you're feeding the bad guys. And how you get rid from the inflammasomes and cancer cells and senescent cells, right? To follow exactly how I can stimulate the autophagy, fasting, mTOR inhibitors. We know many of them. Fasting is one, right? Low carb diet. All of this are mTOR inhibitors. And so you have like 12 hours of mTOR inhibitors, and then you give them the mTOR stimulators, those peptides, right? But you have to clear the weeds. I don't know if you've been in agriculture, but myself, I have my grandfather used to be in agriculture, and I know what he doesn't just give water his trees without cleaning them. Cleans all the weeds and make them ready, and then he fertilizes them, right? Same thing for humans. We have to learn how to alternate between mTOR inhibitor and mTOR stimulators. So, and also all the time, you need to put in your mind, when you manage chronic disease, metabolic, immune, regenerative, oxidative. And there's genomics that Dr. Delal here, she brought them, and she say, well, we can come up with redoxomic, regionomic, metabolomic, add omic to the end. Yes, there's genomics. There's genes that express the antioxidant. There's genes that express all those growth factors on the regenerative. There's genes that express all those metabolites, and we can definitely modulate them. And see all the SNPs and work around them and use the AI, because the AI will tell you if the AI we have right now, we can come up with the way that we use the AI. Okay, you take the data from the patient, all the data, you take the soap, you take the history of the patient or the, when they come in, there's questionnaires, they answer them, and then you do your physical exam, and then you can ask the AI based on all this information, what is the lab needs to be done, and then AI will give you that. Okay, and then you put the lab results, and then you ask the AI, okay, so what is the suggested treatment and management? And the AI can tell you, but you still, as a doctor, you need to choose, because sometimes the AI are sensors, they don't really come up with too much of plan, or a plan it's not make sense. So you can go ahead but it reminds you, gives you some guidelines, and maybe remind you things that you forgot, because our AI, they have more data than us, and it's a tip of your finger. So use it right, use it wise, and if you're able to communicate with AI, he will give you the information exactly what you need. Okay, and you can, by the AI conversation, you can remove all the junks and all the things, and we can benefit from that. It will speed the whole process, because they can read the genetics, they can lead the lab better than you and give you all the data and tell you, okay, well, you want to get rid from, overcome the SNPs, okay, give them this. If you want, they have this problem, give them that. And so I want every doctor here to have to use the AI. And again and again, as integrative doctors in your clinic, you have to have a system that monitors the efficacy of the treatment functionally. It's not enough to just say, oh, lab-wise, chemistry-wise, sometimes it does not translate perfectly to functional. Or sometimes you perfect the lab and you think, okay, we fixed here, but there's other problems that's leading to leaking of the free radicals, that still the patient has oxidative stress. But yeah, but I fixed his ESR, or I fixed his, but still the patient's having problem, not feeling good. You can pick it up better with functional testing, like endothelial function tests and ANS. Those are the sensors. It tells you, hey, you still have free radicals, you still have mycotoxins causing the inflammation that you did not see. So the endothelial function test in ANS, it just tells you whether the patient is functionally good or not. Functioning is will or not just chemically, but functioning. And sometimes we fix those chemicals and we think this is the reason why the patient is sick. Oh, we fix it. We remove all the bugs. You don't have any bugs. But yeah, but still he has inflammation. His endothelial function is not good. So maybe it's not about bug. Maybe he has autoimmune. Maybe he's having vitamin D deficiency or some SNPs and methylations that needs to be fixed. So that endothelial function test, if you optimize it, then that's good. You did good. But if not, then there's some other source of free radicals you did not catch up. You need to screen the patients. And you need to all the time in your mind, okay, look for all the oxidative free radical generators, where they can come from. Look for immune imbalance and see if there's any. Let's balance it. Let's see if there's any deficiency in the metabolism. Maybe his chemistry is not right. Let's perfect it. Let's find it where it is. Right? And then at the end of the day, you can go ahead with the regenerative part, whether with peptides, the cycling of mTOR inhibitors with mTOR stimulators, the exosome, the stem cells, the light therapy, and all that stuff. We can do the regenerative, but after we do the basic things, so your treatment and your management will become more effective, makes more sense, and then you can guide your treatment with a diagnosis that gives you an instant result, which is the endothelial function test with pseudomonas. I don't care from where you're going to get the system. That doesn't matter for me. More matter for me is to have the system. Now, you cannot be an integrative doctor and say, I'm an integrative doctor, and you don't have measurements for your integrative therapies. You don't have endothelial function test. It's like you go to the car mechanic, and you say, well, you know what? My car is broken, and this car is like 2020, right? And you start, okay, well, let me check. Okay, let's hear the yeah. Well, let's see the oil. Let's see this and this and this. No, That's old school. Today, you have to put a scanner in the car to detect this. There are sensors there that tells you there where the abnormality and tell you exactly where the problem is. I don't know if you've been a mechanic, but those mechanics, they don't rely on, used to be putting a stethoscope too. They have also sound. They put in a motor there to hear the sound, clicking, and all that stuff, and translate the sounds. You still have to do it. You have to do stethoscope and temperature and all that stuff. That's what we do. But now they do a scanner. After you do the scanner. So do we have scanners? Yes. This system is like a scanner. It just gets you the heart variability, it gives you unity of function. It's a scanner that everybody needs to have in your clinic. And if you don't have it in your clinic, you're not integrative doctor. Because you're not giving, you're not monitoring the effects of the treatment. You don't know whether your treatment is working or not. You're just telling the patient, oh, you feel good. Okay, good, wonderful. Sometimes some doctors will say, I don't need all of this. I just want to go with my hunch. And they will say to the patient, okay, let's go. I feel that you need sex hormone and you need some light. Even he didn't check his lab. Say, well, based on his facial expression and personality, he's going to read them. And he start doing all the treatment. And then he tell the patient, okay, we're going to fix you. This is going to help you. And the patients believe in it. And oxytocin goes up. And yes, oxytocin can cause a treatment, can restore the physiological process of the body, and the patients feel better, right? Because of the hope and the promise that you give, and this is going to help you. You know, I have patients that they are sick, and they're really sick, and they have problems. But just you tell them, in this fluid, you're going to treat, there's medications that are going to help you and treat you. And it could be just normal saline. And the patients really, they are suffering from pain, the pain goes away. They say, I don't feel any more. It's not psychologically effect. It's really physiological, because throw the hope that this is going to help. His oxytocin goes up, and it does help the patient. It does help to decrease inflammation. Oxytocin is a powerful anti-inflammatory. And so, I mean, but we need to really, I'm not against, being positive for the patient and being also realistic at the same time. But also, I need to have something that really shows definitely that your treatment is working, not just by oxytocin, by all the therapies that navigate all the abnormalities. So what do you want to do? How we come up with at least basic things that everybody can afford it, and at least get the patients interested. It's common sense that everybody after 50, that their sex hormone drops. And that's where the whole process of aging starts. That's where the whole chronic diseases start triggering and coming up, manifesting. Start having diabetic type 2, hypertension, lack of sleep, obesity, visceral fat, gynecomastia. Is that what happened? Metabolic syndrome, estrogen dominant syndrome, and increased risk of cancer, and all this inflammatory and autoimmune disease. They start popping up. And possibly the sex hormone was putting them down, because sex hormone is regenerative and it's anti-inflammatory, right? But when sex hormone drops, and also it is antioxidant because it expresses antioxidant. So it's covering all these 3-4 things. The metabolic regenerative, it's regenerative, yes. Progesterone and testosterone stimulate the growth of muscles. And yes, it's regenerative, it's metabolic, it's immune. So the sex hormone was taking care and putting all those genetic SNPs under cover or taken care by the sex hormone. But once you reach the 50 and the sex hormone drops, and I think Dr. Ziti relate to that, because one time me and her, we been talking to the compounding pharmacy, I remember, and she say, I'm putting my patients all in sex hormone, and if you don't give them sex hormone, they atrophy, degenerate, and eventually they die. Like this to the compounding pharmacy. I remember that. I don't know if Dr. Ziti is here or not, and this event, but if she is here, she will confirm that. And that's true. There's true behind it, because those sex hormones, they are regenerative and they are anti-inflammatory, and we need it. And that's the difference between old and young, is that the youngsters are sex hormone dominant creatures. After 50, we are cortisone dominant creatures, because sex hormone drops. Male and female. Female is more. That's why the female, they age more faster than male, by the way, because our sex hormone does not drop dramatically that like they do. That's why when you want to marry, just try to marry 10 years difference, because at the age of 50, you can show that women's they age more faster than the guys. Me and my wife, difference between us 15 years. I do encourage, to have that age difference. So you will see her all the time she's young, and you don't start thinking about other things. Just teasing the guys here. Hopefully the women's here, they're gonna upset. But what I'm trying to say, even you as women, try to look for who is more age, so that you look beautiful in front of him all the time, and that you don't age faster. But here's the thing. But what about if you interfere and you start giving the sex hormone at the age of 50 and you balance it? Then you can go ahead and say, yeah, I can manage even if there's age difference, 1 year, 2 years, and I can keep my aging process slow because I am giving or taking sex hormones. Then that will balance the whole thing. Then you don't need to look for the age difference. And that's true. I can see that all the women who are doing sex hormone, they look young. And especially they add exosomes and all that stuff. Really, they age of 70, but they look 40. And why? Because of the sex hormone. It's an anti-aging drug. It helps you tighten up the skin. But very important that sex hormone is not enough. You need to make sure that they're happy, because of being stressed out and you have cortisone, that negate the purpose of sex hormone. So they must be happy and taking sex hormone, not just taking sex hormone. The other thing about happiness and good life and not stressed out, it increased oxytocin. So the relationship between men and women, if they're good, then the oxytocin is high. The oxytocin plus the sex hormone she's taking, plus the low cortisone from the stress, then yes, then definitely she will slow the process of the aging, and she will look young all the time. And that's what we need. So it's not just enough to give sex hormone and she doesn't have a good, happy life with her partner, or not happy life with job or things that she does. It's very important, even when you work, you do things that you enjoy. If you work and you do things that you don't enjoy, you will end up with cortisone and you will end up aging and having all the disease. Even if you have a lot of money from the job that you are working. Many money, yeah, it takes care for a lot of things. But still, if you are stressed and you don't enjoy it, you don't get oxytocin out of it, really, it's going to be stressful. Oxytocin is very important. Sex hormone is very important. And because of that, what we can recommend to everybody? We can recommend to everybody above 50 to take cyclodextrin nanoparticle encapsulated intranasal progesterone at night, along with oral melatonin. Okay, let's go ahead and break that step by step. Understand why. When you get to the age of 50, the cholesterol, instead of making progesterone, and then from progesterone you make testosterone, most of the testosterone in the male will be released. A few of them will turn into estrogen. You need some estradiol because it stimulates the high density lipoprotein, so it's good for your vascular health. So men need estradiol, small amount, for stimulating the high density lipoprotein to clear up all this oxidized cholesterol and all the bad fat. And in female, they will convert the progesterone into testosterone, and the testosterone, most of it will convert to estrogen. Few of them will stay in testosterone. You need it, helps to increase the libido and many other things. But we need more of estradiol and estriol. We don't need much of estrogens, because estrogens are the bad guys. Even in male, we don't want estrogens. And testosterone can convert to estrogens, especially if they are aromatase active. And what makes aromatase active is obesity and fat tissue. So the more fat tissue you have, the more aromatization you have, the more estrogens you have, and the more cortisol you have. Because estrogens cause the cholesterol to make more cortisol. It's a culprit, and although it's part of sex hormone, but it's a double agent, estrogens. It's the bad guy. You want estrogens to be converted back into estriol. Who does that? Iodine. Iodine. And you want to prevent the testosterone estradiol, an estrogen, to convert to estrogens. Who does that? The progesterone. And you want to negate the excess of estrogen effect on the body, which is the growth, because estrogens are proliferative and inflammatory agents. That's not good. That sounds cancer. Anything that leads to inflammation and growth, that's a recipe for cancer. That's estrogens. What about estradiol? Estradiol is anti-inflammatory and proliferative. Well, the anti-inflammatory side sound good. Proliferation, you need regeneration, right? But as long as it's anti-inflammatory, that's a good thing. Estradiol. What about estriol? Estriol is anti-inflammatory and anti-proliferative. It's same like progesterone. Estriol and progesterone works the same thing. And so what we need is that to give everybody above 50 progesterone, because progesterone will feed your sex hormone. Now, not progestine, the big pharma product, that's different. Progestine does not convert into testosterone, the synthetic, but the progesterone does. So those AI, when you ask them about progesterone increase the testosterone, some of them they say no. Yeah, because they are relating to progestine, the chemical one. The chemical one does not convert into testosterone, by the way. The progesterone, the bioidentical one, does. So how you persuade the AI? Say progesterone and testosterone increase in production. Then you will see the AI say, yes, progesterone converts to testosterone through the gonads, and leads to increase of testosterone. So this is the AI, because the AI, what I can say. The AI is, let's say, what is the data of progesterone making testosterone? Well, mainstream medicine, they see it as progestin, and they will write down 60% no. So they will go with 60%. 40% will say, yeah, progesterone, the bioidentical, but that's not too much of publication there. Progestin, which is the big pharma, has more publications. So they will tell you about the progestin, not the progesterone. So you need to know how to speak with the AI to give you the truth, because you can get lies and wrong and misinformed. And that's the difference between a doctor using AI to write his book and being somebody else just using the AI and try to write a medical book. You will see the difference, okay? Because the doctor will say, oh, he can correct it. Our human intelligence and processing information, it's still better than, I mean, they are more faster, but the quality of processing, we are better, because we can definitely, we're not going based on what's being published only, but also we have some instinct and we have mechanism of action, and that guides us to the right, to guide the AI. Okay, so I think quality of processing, we are better than the AI. Quality, not quantity. They can process more information than we do, for sure. There's no question. So using as an AI as an assistant to the human intelligence. As human intelligence, there's artificial intelligence, and you need both really to come up with the right answers and right solutions and right books that you're going to write, and right education as well. Okay, so we agree that when we reach age of 15, we turn into from sex hormone dominancy into cortisone dominance. So we need to stop that by giving, where's the problem? The problem is the enzymes, that with age that convert the cholesterol to progesterone is being compromised or being decreased, their expression somewhere. And also the enzymes that convert the progesterone to testosterone and the gonads, they decrease in their expression with age, female and male, and testosterone to estrogen, right? All this decrease. So you need to feed them more than, and sometimes you need to feed them from outside. And you can say, well, we can start with prognolone, because it's after cholesterol, prognolone, then progesterone. You can do that, but then there's some people that have problem with converting prognolone to progesterone. So, you can start with prognolone and iodine, say supplement, you can start with that, especially for virgin people who never take sex hormone. But then if it's not, and if you don't see much of change, you can start giving progesterone and iodine. And if you give progesterone without cyclodextrin, it's not going to be as effective as you're giving it with cyclodextrin, because cyclodextrin helps to deliver and cause slow release of progesterone in the blood, and it's more effective, 10 times better than naked progesterone. Evidence of that, we have patients cannot sleep 20 years, according to my partner, Dr. Stefan. And they use all the insomniac peptides and drugs and pharma and all that, and when he start doing intranasal progesterone, he falls asleep. Right? Loaded with cyclodextrin, not even topical. So that's mean it just gives us the delivery that we need. And the other part is that the cyclodextrin helps to detoxify the body from all the junks, from the xenoestrogens, from microplastics, from fat-soluble toxin, even water-soluble toxins. So it's like, you can say, 2 birds with 1 stone. So progesterone, with its neuroprotective anti-inflammatory benefit, progesterone regulates the immune system, counter estrogen dominancy because it inhibits the conversion of testosterone into estrone. So it is aromatase inhibitor, and also it manages metabolic syndrome. One way of doing that, in addition, it helps you to sleep, and that's good, very important for detoxing the body. But so its metabolites, which is GABA-like, prognolone, I think, allopregnolone, something like that. But they metabolize as GABA, and it helps to, without affecting the waves and stages of the sleep. By the way, all other drugs interfere with the stages of the sleep. This is get a normal deep sleep, and that's the reason of insomnia after 50, because they are progesterone deficient. That's the reason. Okay, why we? What other thing that happen after 50? Blood pressure goes up. Right? So what happened when you give a progesterone is stimulate the expression of antioxidant and nitric oxide. And nitric oxide causes vasodilation. So instead of giving them blood pressure medication, you can help just by progesterone to lower the blood pressure. Does not mean that you're going to stop their blood medications, but you can decrease the amount of blood medications that they need because of progesterone effect as a vasodilator. What else? Well, if you prevent the conversion of the testosterone into estrogens, or estrogen into estrogens, with iodine and progesterone, of course. Estrogens is a bad guy, because estrogens is the reason why we have metabolic syndrome. It stimulates the conversion of cholesterol to cortisol. It's a double agent, right? Estrogens. It's really betraying the 6 hormone. Although it's part 6 hormone, but they are more into stimulating the cortisol production. And also estrogens, because it's proliferative and inflammatory, it leads or causes the prostate cancer. It's the cause of endometrial cancer. It's the cause of breast cancer. It's the cause even for colon cancer. It's the cause of cancers the top cancers. But the top cancers that happen that we know, they are because of the estrogens. Anything that stops estrogens from being produced and negate its effect by progesterone and iodine, the best thing you can do for patients above there. For people, not patients, for people. I don't even need patients. Everybody in the street, come, you're above 50. Let's go ahead and give you progesterone, intranasal, and iodine in the morning. It's unavoidable, because after 50, everything drops. We need to feed them with the right thing. Okay? And that stops the obesity, because the cortisol, all that stuff, do lead to fat accumulations. And the fat, more aromatase activity, more estrone. So it's kind of a feedback, right? And the estrogens and cortisol leads to more fat deposition. And then you would end up with gynecomastia and visceral fat. So the drop of the 6 hormone is the reason why we see those extra fat. Okay? It's because of the estrogens and the cortisol. And so you are managing metabolic syndrome by giving progesterone at night and iodine in the morning. That's very important for everybody, not patients, everybody. Not patients only, everybody. So it's counter estrogen dominancy, metabolic syndrome, and support the brain health. Yes, because really, it does. And progesterone, by the way, to increase oxytocin and increase the libido. And oxytocin will stimulate the contraction of all the lymphatics in the brain and in the neck. It helps to clear the waste of the brain. That's the reason The second thing you do is to give oxytocin during the morning. Why not night? Because it produces euphoria. Some people, they cannot sleep. If they can sleep with oxytocin at night, that's fine. Just go ahead and give it. But if they don't and they have problem because of the euphoria, then just give them in the morning so they can wake up. And we know about oxytocin, right? Oxytocin is like exactly when the computer crash, what you do reset factory. Well, oxytocin is a reset factory for all the physiological process of our body, all the metabolism of our body, all the antioxidant, redox, metabolic, immune, regenerative. You can restore it by just giving oxytocin. Evidence of that, of course, you can go with biochemistry and publications and evidence, you can get them all. And I have a big lecture on oxytocin and show all the chemistry behind restoring redox, metabolic, immune, regenerative. But why do people take intranasal oxytocin? They don't feel it. It's because they don't get into the brain easily because they're protein and big and they're giving it naked. But if you wrap it with oxytocin, with the psychodextrin, trust me, you're going to get the benefit of it. And you can feel it too. You can feel the euphoria after a shot of intranasal. And I like to add B12 in it too in the morning. We have to wake you up, give you that kind of thing. So, what you need to do also, we need the melatonin at night if somebody has especially sleep problem. But melatonin itself, it's a good thing. It's an antioxidant. It rejuvenate. It has many good things. It's express antioxidants. It aids mitochondrial function. So take melatonin at night. Take progesterone. Melatonin, you can take it capsule. You want to do intranasal of melatonin with cyclodextrin, that's fine. But you know, how much you're going to do a lot of nasal? I mean, you have to be a little, again, practical. With a practical approach. Practical means something practice. Okay, let's do melatonin chewable. Tastes good. And then intranasal, let's do progesterone. Because you cannot do everything intranasal. How much you're going to shoot in the nose, right? It has to be convenience too. Right? So it makes sense. So melatonin, chewable at night, and then progesterone, 2 shots. And if you are EMF sensitive, you need to make sure you avoid the EMF, you close it. Even if it takes you to live inside your clothes, close it. You know, where the EMF is not that much there. Okay. Very important to avoid the EMF, especially if the patient has underlying inflammatory diseases like gout, psoriasis, rheumatoid arthritis. All those people, they are EMF sensitive. And the regulation about the 5G is being done on healthy person. Yeah, healthy person, yeah, okay, nothing happened. Okay, it's good, pass. Yeah, but they don't try it with sick people. It's the same concept with vitamins and minerals. When you're sick, you need more. So the recommended dose of vitamin supplement that apply for healthy people, not with the sick people. And that's the problem with our health system. And money talks and money push things. But we are more smarter as doctors and we know what's the best. They can still have the 5G. They can still have, we can fix things. We can tell the health, you know, how we treat patients. We need to have this physician autonomy back, and we need to encourage that. Morning routine is giving cyclodextrin encapsulated intranasal oxytocin and oral iodide nanoparticle. And those things are not that expensive. You know, I would go progesterone iodide is the must. And then if you want to boost the whole thing, right, give them oxytocin. Why? Because oxytocin, especially those with cyclodextrin. And again, people will say, you know, what about detox? Well, the cyclodextrin that you're giving the patient, and the good news, it's not just fat soluble detoxification, it's also water soluble. So you can get rid from heavy metals, from all the water soluble toxins, extra oxidized LDL. It works like high density lipoprotein, by the way. So you can do both. Water soluble, fat soluble, just by oxytocin. Do we need ADTA anymore? Well, if this does it, so I don't need it. But if it does not, then you may need it. So you check and find out, but you do it efficient. You don't do ADTA first. If you have cyclodextrin, it's in your progesterone and in your all your supplements, then that's enough to detox. And now if it's not enough, which you you can measure and check it and see based on lab, then you go ahead and go do more, right? But if this is taking the whole thing, you have to be efficient with patients and smart, intelligent, and not being a candy shop where what's the best to get the money. Let's do the IV that pays more. If you start your clinic based on what pays more, you're not different between the big pharma. And your clinic is just a candy shop. And that needs to stop because this compromise innovation, adventures, and it makes the people with the big pharma scrutinize this field of medicine, and scrutinize physician autonomy as well. And so we need to be really what's best for the patient. And what's best for the patient, eventually, there is a lot of things will come up because then you get the reward of patients feeling good. You get recognized by medical community, by the patients and all that stuff. And then the revenue and the money will come after. First of all, if you solve the problem and you use your heart, you doing good, and that's your best interest is the patient, and you think about best interest of the patient, trust me, everything will open up. But if you become, it's all about the money and it's all about money-driven procedures and treatments, like a lot of doctors they do, and they say, well, I'm busy, I don't need to do all these things. I already have made good money from the injection of steroids and epidural and all this stuff. I don't need this thing. I'm making good money from doing, all this kyphosis treatment and all this epidural injections and all that stuff. And I don't need this integrative medicine. It's not helpful, and I don't need this headache, and I'm satisfied. My plate is full, right? Okay, those doctors, I don't even talk to them. And because they're not really doctors, they're just trying to rep the patients and rip the system and make the doctors look like money-driven thing. So it's very important, and I think with time, with the freedom and physician autonomy, and possibly changing the insurance to be more about the outcome of the patients. And how do you know the outcome of the patients? Well, they need to implement an endothelial function test, because that's a good thing for the insurance too. Because this endothelial function test will tell us exactly whether the patient's treatment is working or not. And if the doctor is doing all this injection of steroids and his endothelial function test is 50, and they spend almost $20,000 per month for the patients. And that's the reason we find out by statistics, the outcome versus the money we spend to the patient per capita, it's not good. We're the lowest among all the Europeans and Australians and all that. And the reason, because we are directing the money to whatever good for the big pharma money. And that's the problem. And that's the reason the health system of the United States is correctly money driven. And we are following the trend, and what's good for the big pharma, we do it. And it's not about what's good for patients. And that needs to stop. And how we're going to stop that, I don't know. I'm not a politician here, but I just have to say it and mention it. So oxytocin, everybody, intranasal oxytocin is a good thing to give, especially, with the social structure that we have. We don't have much connection with our spouse and friends, and we are a working machine all the time. We don't have social life. And Middle Eastern, they work 3 hours in a day, and the rest is all social life. Their oxytocin is high, it's friends and relatives, because they rely on the oil. Of course, I'm not encouraging to be lazy country, of course, but I'm just saying that that's not an issue for the Middle Eastern. They have too much of oxytocin already. But here in Western country, where we work from 8 to 5, especially if you're working in the clinic and you're not having that freedom, yeah, it's very stressful. You don't have social life. You don't have oxytocin. You may need to give into nasal oxytocin. And also the other thing is that Middle Eastern and Eastern culture, they have relatives. Like me, if I go there, I have 200 relatives, 300. So I can stay with this and camping and all that stuff. It's like busy time. Here, we don't have it because the life and the system is not encouraging the, relatives and all that stuff. It's a different culture. But I like the good about both cultures. There's a lot of good things here in Western that Eastern they don't have. And there's a lot of good things in Eastern culture I like it to be. So what we need is to choose and learn for the good in both culture and try to get the best of both. So there's a lot of things in Western culture, in management, in hygiene, cleaning, and system and regulation. This is the best in West. But it comes into social and relatives and vacations and fun and all that stuff. Yeah, East is better, especially the way we connected. So I live both life, born here in the United States, got my medical degree from overseas, practiced in both Eastern culture and Western culture. I did research, I did education, I teach, I did everything, practice, clinic, and so I have a taste of everything. I'm involved in developing products, formulations, and I'm kind of the person of all the experience that you can encounter. And there is beauty in both culture. And I'm trying to get and harvest the best among both and then guide my life based on, and it's good to travel. Like next month, I'm going to go to Germany, go into Medica and see what they have. The biggest convention in medicine, it's Medica in Germany. They have 10,000 exhibitors. And I want to know what's going on overseas, right? So we don't stuck with living inside the box and think that we are having the best here and others they don't. Maybe others they do. So what are the things we need to do? Is that enough to give progesterone at night, oxytocin, iodide, melatonin? Sometimes it's not helping yet to decrease the weight of visceral fat, or metabolic syndrome. You may need to do more, right? Some patients enough, for some patients not. So let's go to the next. Let's try to give them a cocktail of naltrexone, amloxanox, and metformin. And all this product, they are more coming from the nature with a little tweak from the big pharma. But they're safe because we're going to use low dose, very low dose. Metformin is anti-aging drug, just low dose, and it's coming from the nature originally. Naltrexone, same thing. Amloxanox, same thing. And then with B12, because when you take metformin, it may interfere with vitamin B12 absorption. So make sure you take B12 with metformin all the time. Anybody on metformin, give them B12. And low inside cyclodextrin, so you can get the detox of fat and salt. So you're working on everything. And you hit all the aspects. Amloxanox, it's very good in metabolism. It's good for decreasing fatty liver especially. It decreases weight. There have been studies about it. It's anti-inflammatory. It inhibits the TH17, so it's immune modulator. It's metabolic modulator. It's redox. It's inhibit the prostaglandins and KFB beta and all that stuff. Amloxanox has a secret that there's no FDA approved that does what amloxanox does. It helps to manage nonsense mutated genetic diseases. Nonsense, only nonsense. So all those genes that cannot be expressed because it's nonsense, they've been destroyed before it's been expressed because they have some codons there that they've been read as nonsense and they start cutting them off. They don't allow them to be expressed, like cystic fibrosis, one of them. There's one disease, which is Baker's myopathy, the child, the problem with the proteins that they make to connect the skeleton cells with the outside. Those are nonsense mutated genes. Some retina pigmentosa are nonsense mutated genes. You can treat them with amloxanox or help them with amloxanox. I have patients with cystic fibrosis doing very good with amloxanox. I'm not saying the severe cases, but at least, you can get some improvement there, 50%. Just by giving amloxanox. But amloxanox is anti-inflammatory. It's a histamine. It's antihistamine, so it's mast cell stabilizers, which is very good because part of spikopathy, the spike, it activates the mast cells, and then you have mast cell activation syndrome. I think it's similar to symptoms. A lot of symptoms come out with spikopathy. So amloxanox can help that. But it helps in metabolism, helps to increase the sensitivity of insulin, same like metformin. It's helps in shrinking the fat, breaking down the fat, burning the fat, and instead of and then naltrexone helps to decrease the appetite and inhibit the TH17. We know if you have too much of fat, the visceral fat is a source of activation of TH17 inflammation, by the way. Visceral fat is it's inflammatory tissue. So the less visceral fat you have, the less inflammation you have, right? And so if you do a cocktail, you can do the GLP-1, the glucagon like peptides. That's one way. And we are going to develop GLP-1 loaded with cyclodextrin, because one of the problems with GLP-1, if you give it by itself and you shrink the fat, you end up releasing all this free soluble fat toxins. That causes part of it causes that feeling of yucky. I cannot take it anymore. I feel like nausea, and it's because of the fat toxins, fat soluble toxin that's being released from the fat as you shrink them. And that's part of the intolerance mechanism of intolerance. And some people, they don't like the GLP-1. Well, if you see those people, they are loaded with toxins. That's the reason. And when you shrink the fat, toxin goes out and they end up feeling bad. So how we can negate that? Load those GLP-1 and cyclodextrin. And that's the next adventure that I am heading to. Is there any companies are doing that? Yes. They're working on it. It's not yet out. But I need to get so that's the whole thing here, that we are learning from each other here, and also we're developing what's going to be next. Take advantage of this and put those together. You end up solving this problem. Problem is here. Okay, let's do GLP-1 loaded cyclodextrin. The problem with peptides, they don't last long. They get degraded. Okay, let's load them with cyclodextrin. And that's what's going to come next. That's what I'm working on. So get all of this, put it together. You can add acarbose, which inhibit the absorption of sugar, but acarbose, when you have the sugar absorption, they get fermented and they produce gas. Some people, they don't feel comfortable, right? Especially the females. You can give them anti-gas, but they're not compliant with it and they get embarrassed with it. So if the people can take acarbose, it's good. You can give them low dose to decrease the absorption of sugar. If not, then just remove it and give low dose naltrexone, amloxane, metformin. If they're not doing good with this, and I think they will, you do GLP-1 with those cyclodextrin. Or if they don't like the cyclodextrin GLP-1, you do this diet capsule. And so this has already been formed. I already established this thing. I had vitamin B12 because anything when you do metformin, just add vitamin B12. And again, you know what low dose naltrexone does: it regulate the immune system, lower the inflammation, decrease appetite. It's used for off-label for chronic pain, right? Because it increases endorphins. And it's for autoimmune disease because it inhibits the TH17. Anything inhibited TH17 is good for cancer. Ivermectin, one way of the mechanism of it, inhibits TH17. That's like, why? Because if you have too much, and that's what the cancer does. Cancer, it's a very tricky creature. It's a very intelligent creature. I mean, come on. Anybody say, oh, I will treat cancer just by keto diet. I will treat cancer just by insulin. I will be treating cancer just by giving them this herb or this supplement or snake venom or whatever, right? They have no clue what cancer is. Cancer is it's a smart, intelligent creature that they are working to improve the microenvironment, or in other words, make the microenvironment around them in favor of their growth. So it's called tumor microenvironment. They control the tumor, they control their environment, and also they control the inside as well. Inside and outside. They program the whole surrounding to serve them, to make them grow. They make the environment fertile for them. And so what they do to cancer, they secrete chemicals that in a state of, the only way we can get rid from cancer is cytotoxic T cells and Th1 to be active. Because Th1 stimulates cytotoxic T cells. You cannot kill the cancer with neutrophils. But you cannot kill the cancer with antibodies. Sorry, that's good for free things, free floating. When it comes into cancer and intercellular pathogens, you really need They have cytotoxins to go in, attack the cancer cells, and blow it up, right? You cannot just shoot them with antibodies. They will not die. So guns, they just, no, they need really cytotoxic T cells to wrestle with them arm to arm and then poke them with knives. That's how they die, those cancers. But shooting them with antibodies, shooting them with neutrophil enzymes, it's not going to work. They will not die. So they need cytotoxic T cells. So they need cytotoxic T cells and they need Th1 because it activates cytotoxic T cells. So the cancers say, okay, I don't like cytotoxic T cells. And I don't like Th1. What we can do? We're going to secrete chemicals that would move the immune system away from Th1. I would make chemicals that will stimulate Th17 and Treg and Th2. Right? This is cancer what it does, change the microenvironment. So the immune system, Tregs and Th2 and Th7, they will be active protecting the cancer. The Tregs will suppress the immune system, will secrete chemicals that inhibit the Th1 and cytotoxic T cells. Same thing with Th2. That's what they do. Mast cell activation. That's good. Histamine. That will stimulate the Th17 to interleukin 6. And we can grow because we suppress the cytotoxic T cells doing that. So they polarize the immune system away from Th1. And so anything that inhibit the Th17, inhibit the mast cells, inhibit the Th2, and inhibit the Treg, it's going to be the best way of killing cancer because this will lead to polarization of immune system Th1 and cytotoxic T cells and kill the cancer. So any drug you see there, ivermectin, mebendazole, all those things, part of it, I'm not saying all the mechanism, part of it, it inhibits the Th17. Okay, is that enough? No, you need to inhibit the Tregs and move them to inhibit the Tregs because they are protecting them. They're secreting interleukin 11 and they are secreting interleukin 10, sorry, and transforming growth factor beta and all this good stuff that protects them and suppress the cytotoxic T cells. So what would happen? Those cancers will start growing and having fun and fooling the immune system and say, yeah, go Th17, go Th2, and suppressing the main immune system that kills them, cytotoxic T cells and Th1. So when we want to treat cancer, what we do, we need to polarize the immune system. What things we do? Thymosin alpha, interferon gamma, and then do the antibody anti-PD-L1, anti-CTL4, because this will inhibit the Tregs, right? It will block the Tregs from suppressing the immune system, from suppressing the Th1 and cytotoxic T cells. That's why we do anti-PD-L1. And then, okay, what other things cancer does? Secretes those vascular growth, right? Cytokines that helps to stimulate the growth of the blood vessels. Blood vessels, they become kinky. And then they stimulate the fibrosis. The fibrosis will squeeze the blood vessels. And when you squeeze the blood vessels, and they're kinky blood vessels and squeeze them with fibrosis, what would happen? This will prevent the lymphocytes infiltration, allowing only the sugar and all the good stuff to feed the cancer, but no, they block the lymphocyte infiltration by just squeezing up the blood vessel with fibrosis. So now the strategy is to break those fibrosis, give them losartan, give them things that inhibit the fibrosis. Anything that inhibits fibrosis is good for cancer because you open up those blood vessels. And then you need to normalize the blood vessels back to normal, not kinky and twisty and all that stuff, by giving Avastin, right? Which would inhibit those vascular endothelial growth factors and normalize the blood vessels so you can infiltrate the white blood cells and kill the cancer. So anybody out there, they will say, oh, I kill cancer with keto diet or insulin or photodynamic therapy. I did that. You know, I'm even mocking myself because I was 5 years trying to help my dad, and I thought photodynamic therapy is the answer. What happened is that his cancer is fibrotic. So all the photodynamic, all the radiotherapy, all that's being protected. The cancer is protected. It's more smart. Photodynamic will not work because they don't get in. The cancer has been surrounded by fibrosis and Tregs, right? And you're trying to kill it with radiotherapy and all that stuff, but they insulate themselves. In a way, they protect them, and then they turn into stem cells. And stem cells is very resistant to chemotherapy because they have enough of antioxidants, like normal cells, to combat any free radical generations. So you're trying to do, oh, I'm going to induce a free radical, induce apoptosis by photodynamic therapy, blocking with chemotherapy. But those stem cells, they work like normal cells. They can go ahead and take care of that, right? So you really need to know what is cancer before you come up, being fooled like me. I was a fool when I trying to, oh, photodynamic therapy will work and all that stuff, Stop talking like Dr. Juice. That's what happened when you start, being friends, and then you got his quality too. So yeah, where Dr. Juice? You're not involved in him, man. You're listening? Okay. I'm learning. Okay. So that's what's happening. I think we got out of the topic here. So let's go back. That cancer treatment, Dr. Dalal and Dr. Patel, they are very innovative in it. And we don't want to hear more from them because they have experience too in managing cancer. And I need to get their lectures. Dr. Dalal and Dr. Patel, they are pioneers in cancer treatment, by the way, for many, many years, and we need to appreciate their work. And I want to put them on stage as much as we can so we can learn more tricks to manage cancer. You really need to be a magician to manage cancer, right? And I think Dr. Galal and Dr. Patel, and now recently Dr. Jusuf also, he's now involving with cancer patients, and he become a wizard, a magician of the cancer, and know how to play the tricks of cancer and be smarter than the cancer. And really, this is just the iceberg of cancer. And it's a big story. You need a lot of hours of CME and a lot of talk and a lot of challenge and a lot of debates and discussion between those pioneers, really to squeeze out the juice and their experience and all that. So that's what I'm going to do in those. I'm laying down the foundation, but I don't like the one-way teaching. I like the debate and discussion and learning from each other. When the debate is dead and when the discussion is not there and the doctors are not involved, you really are not learning much. And your information that you're giving is not being verified. You need to have scrutiny from all those doctors. And I welcome to the scrutiny, welcome to debate, welcome to the interruption at any time. I have no problem with that. Let's finish it up so we can get the 30 minutes of that debate and discussion and squeezing and so we can learn from those people out there. So I'll go through all of this very fast because I think we are ending the lecture with amloxanox. Everybody knows, we talked about it, metformin, vitamin B12. And the other part that we have recently, the problem we have is the spike detox, the spikeopathy because of the corona virus, because of vaccine. They all give you the spike protein. Well, the reason why, because those immunologists, they don't know better, right? They say, well, in order to really sensitize the body against COVID, we need to have an antigen in the body that is combining to the receptor, because in their mind, when those immunologic doctors were inventing the vaccine, they are more biased about getting rid from the virus by antibodies. And the evidence of that, the efficacy of the vaccine is based on the antibody titers. And you can hear them. Those people who invented the vaccine, they evaluate the efficacy of the vaccine based on the antibody titers that they produce. And that's the mistake. That's the problem. We're going to talk about it. Why is the problem that you measure the efficacy of the vaccine based on the antibodies? Because if you have too much of antibodies, that means you have too much of Th2 and Th17, and you have less of Th1 and cytotoxic T cells. So it's good that you have antibodies to take care of those free viruses that's floating around. But what about the intracellular virus that is mutating inside and that you suppress them by increasing the memory and response of the Th2 and Th17? You have a lot of antibodies, but those cytokines of Th2 and Th17 is inhibiting the Th1 and cytotoxic T cells, so you don't have an immune balance. And if you don't have immune balance, you don't have enough cytotoxic T cells memory and Th1 memories, then you cannot get rid from those intracellular virus that's inside the cells. You get rid from the free virus with antibodies, but not them. So what will happen? Those viruses will say, thank you, okay, you got rid from the outside, that's fine. But me, I'm enjoying my life inside those cells, and I can mutate and come up with a different color and different version and different strain. And then those antibodies, that you sensitize, that you memorize, that you produce and you induce, right? They will not work anymore with this new version that's coming out from those cells, infected cells. So what you need to have a vaccine that is immunogenic, right? But also produce a balanced immune response. They give you enough of Th1 and cytotoxic T cells to clear those infected cells with the virus so they don't mutate, come up with a new strain and fool us again, where you need another vaccine. Yeah, another vaccine, produce antibodies, yes, clears up the virus, but then those viruses will hide inside and change their clothes and come up with new clothes, and we cannot even identify them, right? And you end up with a new strains, new vaccine, new strains, new family. And then what you end up with messing up with your immune system. And not just that, it suppressed the whole thing to the point it put you at risk of having cancer and infection and all the stupid things that we experience now with spikopathy. And then if you stimulate too much of Th2 and Th17, what will happen? You have too much of interleukin-6, mast cell activation syndrome, especially those spikes. They stimulate the mast cells. They hijack renin-angiotensin system, which that means they actually cause the whole immune system to be polarized more of the Th2 and Th17, because those, when you block the ACE2, you led to more activation of angiotensin 2 type 1 signaling, and that is in favor, especially in macrophages, in favor of producing cytokines that polarize the immune system to Th17 and Th2, and then all your immune system is being skewed to the other side of the aisle, and that compromises the clearing of those viruses that's being infected those cells, and also it compromised even cancers, because all those interleukin-6 and all that's coming from those strains that you encounter and all that stuff, all this interleukin-6, they don't know the difference between those cells and other cells, so they suppress the whole Th1. And you end up having this problems that we have, which is increase in the rate of cancers, right? The spikopathy. And then when you activate the mast cells, you end up with mast cell activation syndrome. Everybody know mast cell activation syndrome, right? Is that what happened? Fatigue, right? What else you can feel? Blood bloating, rashes, brain fog, triggering all this inflammatory diseases, autoimmune, because that's autonomic dysfunction, autonomic nervous system dysfunction, all this crazy things that happen, and it's because the vaccine is not well made, where it has to follow this. It has to be immunogenic, non-pathogenic. That's the problem with the spike protein. It's pathogenic, right? And it produces a balance of the immune system. So I want that vaccine. Give me that vaccine. I will shoot that vaccine if it's immunogenic, non-pathogenic, and produce immune response. And this vaccine, the COVID vaccine, does give you immunogenic. Thank you very much, Peter Hotis, for doing it. But the problem, it's pathogenic. And the other problem is immune imbalance. And he experienced that before when he developed the vaccine for respiratory syncytial virus. There was a problem there because it was pathogenic, the vaccine, and that led to increased activation of Th2, mostly, not Th17. It's Th2 dominant with some Th17, and that leads to basophilic pneumonia, basophilic pneumonia and basophilic vasculitis. What about the COVID vaccine and spike protein? It gives you more of neutrophilic vasculitis and neutrophilic pneumonia. So neutrophil is high. Well, neutrophil is high. When we see it, we think, oh, this is an infection of bacteria, right? People think it's bacterial infection. The immune system is being fooled by the spike protein. Normally, the macrophage will take the virus and produce, you'll see lymphocytosis. And with lymphocyte mapping, you'll see CD8 and Th1 is high. But in this virus, infected, is fooling the immune system. It makes it look like they were affected by bacteria. Why? Because you will see more of Th17 and interleukin-6, which is good for killing the bacteria. The neutrophils are good, but it's not for the virus. You cannot kill the virus with neutrophil, especially if they infect inside the cells. You really need cytotoxic T cells. So spike protein did fool the immune system and make the lung fragile. And that's why when you do all this oxygen with intubation, the lungs are frail and they blow up and they die fast. So that's another topic. But how we get rid from the spike protein? Okay, we get rid from it by breaking it down. what things that helps to stimulate breaking down protein? Nitrokinase and bromelain. They stimulate the digestion and breaking down of the protein. That's a good thing about nitrokinase and bromelain, and possibly they will break down the spike or stimulate the proteases that breaks down the spike. Bromelain stimulate the proteases that breaks down the spike, and nitrokinase actually itself, it breaks down the protein, including the fibrin and the clotting. And we need that because we know the spike protein, when it's stimulated Th17 and the interleukin-6, and interleukin-6 is stimulating the clotting and the fibrosis and all the problems that we experience with spikopathy. So you need something that breaks down the fibrin and breaks down the spike protein. And I think a combination of, and this is Dr. Pedro Macala cocktail. I agree with him. Curcumin helps it have the Th17 to have the effect. I add methylene blue because it does help to bind with the spike protein and helps them neutralize them. Same thing it does with priones. So, but it does not break them like nitrokinase and bromelain, but it helps to just touch to them and prevent them to attack the ACE2 or bind to the ACE2. So that's a good thing. But cyclodextrin itself can cause conflicts with spike protein and get rid from the spike protein. So it's a detox for spikopathy. So cyclodextrin loaded with all this. Hopefully we're going to have this soon. Mike Emanuel can make it for us. And then we have a detox formula that does what we want for basic things for spikopathy detox with a combination of all this formula. So it's very important that we load our drugs with cyclodextrin. I think it's the new trend. Even Pfizer and all the big pharma, they're using cyclodextrin to load their drugs, especially peptides. It's good to be loaded with cyclodextrin. And then is that enough? Well, and when you do injectable, when you do antibodies, or you do chemotherapy for the sensitizers, it's not just enough to load them inside cyclodextrin, because the cyclodextrin is only 1 nanometer. If you want to target the cancer, which is leaky in pathology, especially for the injectable I'm talking about, it's better if you clock them with platelets nanoparticles, so you can end up with a size of nanoparticles up to 100 that will trap inside the pathogens of the cancer and inflammation. So for us, as you know, all those CDPM doctors who are adapting already platelets nanoparticles, encapsulation, they can use cyclodextrin to stabilize the drug, yes, and then they can clock them with platelets nanoparticle. And that's the training that I provide. I provide almost 10 to 12 doctors to do platelets nanoparticle, including Dr. Patel, Dr. Joseph, James. I hope Dr. Della would follow, because that will enhance the whole process of treating cancer. You need the platelets nanoparticle. So cyclodextrin is not a replacement for platelets nanoparticle. You need to clock them so you increase the size up to 100, because cyclodextrin gives you 1 nanometer. That's not good. To target cancer, you need the 100, because the 100 up to 100, the blood vessels of the cancer will leak them, and the healthy tissue will not allow those platelets nanoparticles to go in. So then you get more drugs going to the cancer, right? Cyclodextrin, if you want to go to everywhere and just release and stabilize it, cyclodextrin will be good. But if you want to target cancer, you need to do the platelets nanoparticle. And that's the new trend of medicine. Every person here who's doing cancer need to do platelets nanoparticle. That's a condition. In order to be CDPM official doctor, you need to learn how to do platelets nanoparticle. The process of doing platelets nanoparticles will help you to learn how to even load anything into nanoparticle, including cyclodextrin, because they use the same process. So if you know how to do platelets nanoparticle loading with drug, you can do cyclodextrin loaded with drugs as well in your clinic. And you can, all your supplements, all your drug, all the injectables can be loaded in nanoparticle in your clinic using the technology that we are providing as a fellowship program. Now, again, every integrative doctor has to have endothelial function test. I don't care from where you're going to bring it. If you don't have an endothelial function test, ANS, pseudomotor, you're not a functional doctor. Okay? It's going to be a stigma. If you don't have it, you're not an integrative doctor. You have to have it. And I don't care from where you're going to bring it, but you do have to have it. It's like a mainstream medicine going to the patient without stethoscope, or without a thermometer, or without oximeter. ER going to check the patient without oximeter. It's not an ER, right? Without oxygen, how are you going to manage the patient? How do you know what's going on? So endothelial function test is very critical to know, especially for managing chronic diseases. It's a good guide to guide your treatment. And I think this will be the end of it. We have the conclusion here about using it's so affordable to do it, right? And I use the basic things to start so the patient feels good, and then you can go ahead. Does not mean that you don't do the labs. I don't want candy shop throwing medications. In the process of giving this, you need to check the lab, but you don't want just to do the lab and wait for the lab. You can do the gene function test. You can start this at the same time you pull the blood from the patients to do the lab. And then you go ahead and then see if this is working after 3 months or during the process, whatever you think that the patient needs to visit you again to interpret the lab and confirm what you're doing is helping, and add more if needed. And then that's how you really start, because doctors, they want to know, they want to structure this field of medicine. And I'm trying to structure it. I'm trying to put protocols that all the doctors can follow, so that we can explain to the mainstream medicine, they can adapt it, because this is kind of, we call translation research, translating from all this innovation into practical protocol where the mainstream medicine can adapt it. Big pharma, they say, okay. And the title that we're using is Chronic Disease Prevention Management, CDPM, which is being pleased by the American Medical Association. They have a group, it's called CDPM. And I think that the system, they don't want you to be labeled yourself with how you treating diseases. Don't label yourself with integrative, regenerative, because then they feel that this is going to limit you from doing the big pharma products, and this will take all the money from them. So they want you to label yourself with what you're treating. You're treating neurology, nervous system, gastroenterology. You're treating internal medicine, right? That's what you're treating. But internal medicine means using big pharma product. That's internal medicine. That's the medicine for. But in order to really come up with a title that bridges between conventional and integrative is, I think, CDPM is the best umbrella up to now. And then you can, under that, can be holistic, homeopathic, regenerative, integrative, mainstream medicine, internal medicine, oncology, integrative oncology. All of that can be, you can practice it, but just use an umbrella that will not put you on the watch, and that you tell them, hey, I'm just preventing and managing chronic diseases, and this is what AMA is encouraging us to do, and I learned from them that 360 HP history physical exam. Now they recognize that you cannot treat the system as mono. You have to take the history physical exam from all the systems and include all the social factors and be more comprehensive when you are managing the patients, because they see that during COVID, most of specialists fail to manage it because it's COVID disease. It's a multisystemic disease, and patients start being referred from one specialist to another and got lost in the weeds. So they understand the importance of somebody can take over and really come up with a protocol that is comprehensive, that will manage the disease from all different perspectives and all different level, and integratively, and include all the systems of the body. So I think we end the lecture by the conclusion. We have here to another 30 minutes. We might have Dr. Joseph, Dr. Stefan here too. He joined us, and he's gonna coach us tomorrow for doing exercising. He's gonna wake us up at 8 a.m. and really is gonna, we're living in the beach here, so there's 1 hour in the beach running and all that stuff, and then another 1 hour doing gym. So this is Dr. Stefan. He's our coach. And Stefan, Dr. Joseph, come on, man. Mike is yours. I'm hungry. I didn't eat my burgers. Did you eat your burgers?
I'm gonna have some raw yogurt.
You did not even cook the burgers.
I'm gonna train them.
Okay, so let's go.
They can
ahead
lift
and do
weights
this
tomorrow.
While you talk to them, I'll take care of this. Okay. See, I'm the cook. I'm the teacher. I'm the educator.
He says he wants